factors for cancer of the esophagus is smoking and alcohol intake. And these are more common in men than women. And that's why there is that association. So as you responded right, that the predisposing factors, but majorly smoking and alcohol are more prevalent in men than women. And therefore it is thought that maybe this could be raising the instance of esophageal cancers in men as compared to women. So thank you again for those reactions, and we thank our presenter again. I'll make a few comments about cancer of the esophagus. As the presenter mentioned, it is one of the prevalent surgical conditions in the world. He gave us the instances for North America, but I think globally it is the sixth commonest type of cancer. In Uganda, he gave us the instance for East Africa as the fifth commonest cause in East Africa, but in Uganda, it is actually the sixth commonest type of cancer. He gave us the distribution for the different types, the squamous cell carcinoma and adenocarcinoma. And in Uganda, per se, in Africa, we see more of the squamous cell carcinoma than the adenocarcinoma, and that is the reverse for the other, the Western world. They tend to see more of the adenocarcinomas than the squamous cell carcinomas. We have talked about the predispositions among male and women, more common in men than women. In terms of age, if you look at general factors, age, the older patients, age predisposes almost 63%, increases the risk by 63%. Smoking increases the risk by 63%, and gender is only 17% distribution. So gender, whether you are male or female, will increase your risk of esophageal cancer by 17%. But age will increase your risk of esophageal cancer to 63%, and smoking will increase your risk by 63%. You can read about this in the paper by Ochama, published at Mulago in 2008, where he looked at these distributions. Then the other factors that, again, we can look at the distribution in the country. Obayo, again, at Mulago, has done some publications looking at the distribution of esophageal cancer in Uganda. 34.2% were in the central region, 15.67% in the southwestern region, 8.9% in the Elgon region, then Eastern Central, 8.29%. That was the distribution from, this is at the Uganda Cancer Institute, depending on how the patients came in at the Cancer Institute and the regions where they came from. Definitely, as you know, that the central region has a number of people. It doesn't mean that central, you are born in the central, but the number of people who are living in the central region from different places. But if you take that as a demographic distribution, most of the people come from the central region. It needs to go further into the factors. The people in the central region more predisposed to factors leading to esophageal cancer as compared to those in the Southwest, Elgon, or Eastern region. And again, Obai again contributed that among the tribes in Uganda, the Baganda, the Banyankole, the Bagisu, the Basoga had higher infections, had higher manifestations of cancer of the esophagus as compared to the other tribes. But this data is from the Uganda Cancer Institute. Remember that there are many people who have cancer of the esophagus who definitely die in the villages, and they don't even reach the nearest hospitals to them. So definitely, if you did a whole survey of hospitals in Uganda and presentation of esophageal cancer, you may get a different picture. But at least we can rely on that published data to sort of understand the picture of cancer of the esophagus better in Uganda. We have been talking about the gender distribution, but Obayo, again in 2023, reported that 70.23 patients with esophageal cancer were male, 29.77 were female, with a mean age of 60.2 years. So that, again, affirms the distribution that the presenter gave us about the distribution of esophageal cancer in according to gender. So that again is affirmed by that publication. Still from his work, Obai has confirmed that alcohol and smoking were major predisposing factors. 39% of the cancers were in the lower third. That was 39.2% in the lower one third. Majority of these, which is 90.74, were squamous cell carcinoma, and 9.2 were adenocarcinomas. Most of these patients presented with a poorly differentiated grade, nearly 37.8 had poorly differentiated grade, and majority were in stage 4B. The presenter gave us those stages. So 37.3 presented with this sort of differentiation of tumor and staging. And it is true that most of your patients, as you will see it in Mubende and other centers that you work in, that patients present with late disease. And that one, we are going to look back a bit into the presentation of esophageal cancer. So by the time patients notice that they can't swallow, they now can't swallow solid foods, and that's when they remember to come to hospital. And usually it is late. Now, the 5-year survival for esophageal cancer is reported to be around an average of 20%. It ranges between 5 to 47%. But definitely, when you get this early, you can definitely increase survival. And survival for these patients is much better in centers where they have specialized in treating esophageal cancer. So the presenter gave us the history of how the tumor presents, how the disease present. He took us through the anatomy. But majorly what we need to remember is that as he gave us the anatomy, the esophagus connects the oral cavity to the stomach, and therefore it is a conduit or a passage for the foods that we take in. Now, once a cancerous lesion develops, one of the earliest symptoms is the dysphagia, and the presenter gave us those different stages of dysphagia. But commonly, patients present with failure, difficulty in swallowing, and they will report, yes, I began by difficulty in swallowing solids, but now I have difficulty in swallowing liquids as well. And some of them come when they can't swallow anymore. I mean, even saliva can't go, but they usually have that history of difficulty in swallowing solids, followed by difficulty in swallowing of liquids. And of course, there are other symptoms, loss of weight, weakness, and all the other symptoms that are related to the sequelae of malignant disease. So it is important that in your history, after you have captured the presenting symptom, then explore for the other factors, as we have said. History of smoking, history of alcohol use. Now, in our country, we don't use hot foods a lot. But in Asia, where I think the continent with the highest incidence of esophageal cancer, they use hot foods a lot. But of course, cultures are changing. It will be good to know whether people are using hot foods. They may have traveled out of the country for many years and lived in these parts of the world where they use hot foods. So it is important that you ask about the nature of the foods that people take at home. Then one of the countries that has had a long history of esophageal cancer is Japan. And in Japan, eating smoked fish is a culture. But these foods which are preserved through drying and smoking tend to develop what we call nitrosamines. And nitrosamines are carcinogenic. And nitrosamines have a very high relationship with carcinogenicity of cancer of the esophagus. So it is important to discuss or find out from the patient their dietary intakes. Definitely in Uganda, we have had a culture of preserving foods, dried foods, for many, many years. Actually, smoking of beef, smoking of fish was like the way to preserve food. If you slaughtered a goat on Christmas Day, you had to reserve a piece of that for relatives who would visit you in the following year to share. If it was a festival, maybe a wedding, and an animal was slaughtered, you have to preserve some meat for the relatives who will visit you to congratulate you about the function. And that meat used to be reserved for 6 months, 7 months to smoking. But even now, you will see it that selling of dried fish is a common commodity in the fish markets. we have not studied to know whether this fish is safe. Has it got nitrosamines? The good thing, it is consumed quite maybe urgently. It is not kept for years. But the science shows that these foods which are reserved like this have nitrosamines, which lead to esophageal cancer. Then the other predisposing factor which you may need or you may ask about, for example, it is known that the human papillomavirus may have a relationship with cancer of the esophagus. Read about these studies about human papillomavirus and how it is causing new cancers, like cancers of the throat, cancers of the esophagus. These are new epidemiological changes that are occurring because of behavior, human behavior, that is leading to these viruses affecting new systems. Definitely, the esophagus is prone to getting infections with herpes simplex. It is known to get cytomegalovirus infections, Epstein-Barr, but these ones have not been shown to cause malignant transformations of in the cancers of the esophagus. So, but what I asked you to read about is the HPV, human papillomavirus, with the evidence papers that have been produced concerning cancers of the esophagus. Definitely, as the presenter mentioned, that we have to investigate these patients. Definitely, you have to think about the differentials once you get these patients. And one of the first differentials is achalasia. Achalasia is a motility disorder of the esophagus. But for achalasia, the patients will present with difficulty in swallowing for both liquids and solids. Unlike in cancer of the esophagus, where there is progressive dysphagia of some solids and then to liquids. The other differentials definitely are esophageal webs, diverticuli, esophageal candidiasis, gastroesophageal reflux disease. So that is why investigating the patients is extremely important, so that you can confirm what could be the primary cause of dysphagia. And the primary investigation we do is a plain chest X-ray if patients have dysphagia, a plain chest X-ray. But this will not be very informative in patients who have cancer of the esophagus primarily, unless there is metastasis and advanced disease, maybe with refusions. Okay. So, but again, if you see an effusion, it will be difficult for you to say this effusion is because of a cancer of the esophagus. You definitely think of infective causes. Or if you have coin lesions, you may have other primary tumors in other parts of the body giving you the coin lesions. But the most informative investigation is the barium swallow. The barium swallow has a sensitivity of about 94%. And here you have to differentiate between doing a single contrast and a double contrast barium swallow. So this one is extremely important for you to, wherever you talk about contrast studies, you have to talk about either double contrast or a single contrast. So then, but this one will show you, as the presenter showed us that picture of constriction of the esophageal lumen. This one you'll definitely get clearly on a barium study. And then after you've done a barium swallow, the next thing you're going to do is an endoscopy. An endoscopy has a sensitivity of 90 to 94%. But it has a specificity of nearly 22%. But it has a very high sensitivity. And you'll be able to see the lesion, and you can take a biopsy for the lesion. You can also do stenting using the endoscopy. So it has all those advantages, but as an investigative modality, it has a sensitivity of 90 to 94%. Then we have the endoscopic ultrasound, which can also be used to assess the primary lesion, but it can also assess metastasis, and it can be used for surgery. As the presenter said, you can do endoscopic resection of those mucosal lesions as a surgical intervention. CT scan is good, but basically for advanced disease, it has a sensitivity of 30 to 60%, but is very good for studying advanced disease. That is disease that has grown beyond the esophageal wall into the trachea, metastatic, into the higher lymph nodes, into the lungs and other parts of the body. So a CT scan becomes a very, very good modality to use. Then the PET scan, as the presenter told us, this is very good if you have bone metastasis. Really, it will do a lot to tell you if there are, metastasis within the vertebrae, but that's different lesions. So that's when the PET scan becomes very good for those bone distant metastasis. The treatment for esophageal cancer, as the presenter said, depends on the staging. Some of the patients who present with early disease, they will benefit from primary resection. As we've said, those who have mucosal tumors, they can be removed by endoscopic ultrasound, endoscopic resections. And those who still have early disease can have esophagectomy. But then those who have advanced disease will have to have the palliative procedures, as the presenter told us, using stents and maybe feeding gastrostomies. So the decision on management will depend on the stage of presentation. Surgical procedures can be endoscopic, as we have said, when you are going to resect mucosal tumors. They can be open, okay, as the presenter talked about the transhiatal and transthoracic procedures. He took us through that slide where you saw the different surgical procedures, but they can also be endoscopic or laparoscopic or micro-invasive where you use laparoscopic procedures, and those are new advancements. For the endoscopic resections, they are applied via an endoscope. For oesophageectomy, can be done through the transhiatal or transthoracic procedure. Actually, the transhiatal approach means basically 2 stages: performing a laparotomy and then dissecting the esophagus, and then via the same incision, construction of the gastric tube, which we are going to use for anastomosis, and then the the thoracotomy that you perform will enable you to further dissect the esophagus and then resect the part that you're supposed to resect, and then you anastomose this with your gastric tube. In case you have had a very extensive resection of the esophagus or total gastrectomy, then you have to add a neck incision so that you can do the cervical anastomosis in case you have to replace the esophagus totally. If you have had a total esophageectomy, then you have to add a neck incision for doing the cervical anastomosis. So you read more about these procedures. They are well explained, but in principle, that is what is done. You can also offer an extended esophageectomy where you do an esophageectomy and then you resect the other surrounding tissues like lymph nodes, which have been affected by, or in case of metastasis or sampling. But these ones, you can read a bit more about them. We have talked about the palliative procedures, and that is what we commonly do, at least in Mubende: stenting, placing the tubes in advanced CA, and also gastrostomies. At least these ones we can do, because in most cases, patients, they come late and we offer them those as palliative procedures. As we mentioned from the start, survival following esophageal cancer is very, very minimal. The survival rates are very low, but majorly because patients present late when salvage is almost nearly late. The presenter told us about the other modalities of treatment: chemotherapy and radiation. These can be either adjuvant after surgery or neoadjuvant prior to surgery to downstage the tumor. But there are other modalities of treatment which are being used now, like we have the mucosal ablation using radiofrequency ablation. These are new modalities which are useful in cancers which cannot be resected. We also have laser therapy. Laser therapy targets specific tumor cells in specific lesion. More so if resection is quite complicated, then you can target those cells with laser therapy. So on top of the chemotherapy and radiation, you need to add the mucosal ablation, radiofrequency, and then laser therapy. I'm aware that in Aga Khan, hospital in Nairobi. At least they can offer laser therapy. Some patients have been there for treatment, not only for esophageal cancer, but for different types of cancers, more so when they are quite advanced. As the presenter mentioned, the post-op complication management involves fluids, pain management, but majorly palliative care is very, very important. And that's a big branch of care which you need to be acquainted with. But supportive treatment, counseling, pain control is very, very, very useful. So I think those are the few additions I wanted to make to today's presentation. You can explore more about this topic. Thank you, Sebastian, again for today's presentation.